Hello everyone. As part of our Making Healthcare Better webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I'm your technical producer. It is my pleasure to welcome you to today's webinar, Fever Management, Current Strategies in Patients with Infection. And now, I'd like to introduce you to Mary Cook Sullivan, who is our moderator today. Mary is the current sepsis project manager at the University of California, San Francisco, UCSF. In her role as clinical nurse specialist, she uses her many years at the bedside and clinical expertise to improve outcomes for patients and their families, including delirium screening, ICU liberation, and the early identification of sepsis. In 2013, Mary joined the Sepsis Project at UCSF and has led a multidisciplinary team to integrate continual sepsis screening and associated workflows, including code sepsis in 2 emergency departments and 25 patient units. Mary, welcome, and I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I am, Emily. Thank you so much for that very kind introduction. And thank you for everyone on the webinar today for joining, taking time out of your busy day to join us on this very important webinar on fever management, current strategies in patients with infection. It is my privilege to introduce Dr. Hildy Shell-Chapel, a mentor and colleague who is at the forefront of this very crucial topic. Dr. Shell-Chapel is a critical care clinical nurse specialist at the University of California, San Francisco Medical Center with 25 years of experience in leading interprofessional teams aimed at optimizing safe, high-quality, evidence-based care to critically ill patients. She's published and presented on numerous topics, including care of critically ill patients with sepsis, multi-organ dysfunction, ARDS, liver dysfunction, fever, AKI, and ensuring quality and safety of patients requiring continuous renal replacement therapy. She is currently in a leadership position within the Department of Patient Safety and Regulatory Affairs at the University of California, San Francisco Health System, and is Associate Clinical Professor at the UCSF School of Nursing. This speaker discloses no relevant financial conflicts of interest associated with this presentation. And this educational activity is approved for 1 contact hour for nurses and respiratory therapists. You can see the accreditation statement here on this slide. And support for this educational activity is provided by Stryker. At this time, I would like to turn the presentation over to my colleague and friend, Hildy Shell-Chapel. Hildy, are you ready to get started?
Thank you, Mary, for that lovely introduction. And welcome everyone to this educational webinar on fever management. Let's get started. Okay, the learning objectives for this webinar are for you to be able to describe causes of fever, the fever response, and describe the risks and benefits of treating fever. Also, to list the impact of fever suppression interventions that we commonly administer, and list the mechanisms of action and the patient's response and the adverse effects of treating fever. The outline for today's webinar includes, we'll do a brief practice query, we'll review the concept of fever management, we'll define fever terminology, and also review the current evidence in ICU patients related to body temperature monitoring, treating fever of infectious etiology, the antipyretic medications, and physical cooling measures that we typically administer. So the practice query, for these practice query slides, this is not a poll. Rather, I asked for you to think about how would you answer these questions, these few practice query questions. Think about what would your answer be and then why. What is the rationale for your answer? Like, how did you arrive at that rationale? Did you learn it from a class you took, from your preceptor, a physician, a respiratory care colleague, or a nurse that you've worked with? Or did you read it in an article or research study? Is it your practice because of tradition? Everyone's always done it that way. Therefore, that's why we do what we do and why we have the answers to these questions. So how do you define fever? What is the threshold temperature that you use? Is it a temperature greater than 38? 38.3 or 38.5? And is that number based on, the notified provider order that you have, or a parameter to treat in a PRN, let's say acetaminophen order? Or does it depend on the site of measurement, whether it's oral, rectal, or tympanic? Or do you think, is it more than a body temperature that is how you define fever, including signs and symptoms such as the patient, are they flushed? Do they have chills or rigors? Are they shivering? Do they have lethargy or malaise, that general feeling of discomfort and illness, not really sure what's causing it, but that general malaise, or that they're feeling feverish? The second practice query is for you to think about, when your patient spikes a fever, are antipyretic medications routinely given, or are they routinely ordered? Is this a part of admission orders, or do your colleagues, or do you have to call and notify, and do you request that antipyretics are ordered if they're not already ordered PRN? And then, which interventions do you apply to your patients with fever? These are regarding kind of physical or environmental changes. Do you put blankets on, or do you give patients, do you take their blankets off? Do you turn a fan on? Do you apply a cool washcloth to their body or their forehead? Do you apply ice packs? It's typical for nurses to put them under the armpits and in the groin even. Do you give the patient a bath with tepid water or alcohol? The more senior nurses would know about alcohol baths back in the day to help evaporate heat off the body. Do you apply a cooling blanket? Okay, do these interventions reduce body temperature effectively all of the time, even when you apply them? Have you thought about why or how they affect temperature reduction? And have you thought about, do they have any potential adverse effects, like shivering when you put ice in the groin or under the armpits, or put them on a cooling blanket? Do we see an increase in body temperature when we apply these? Is there any skin injury from any application, or toxicity? And the toxicity is referring to alcohol baths. Those really should not be done, and OSHA has asked that, has advised us against that because of absorption into the skin. And then think about, do these interventions require provider order, or are they within your scope of practice? So those are things to think about. I want to spend a minute on this kind of busy slide, but fever management is more than body temperature reduction. It's more than normalizing that number on the thermometer. This is a fever management conceptual framework, and it kind of follows our nursing and respiratory care processes that we use for providing care in terms of assessing our patients, planning their care, applying and administering interventions, and then reevaluating them. So the first thing is fever identification. So we need to monitor patients, and it requires temperature measurement, or what we call thermometry. And the accuracy of body temperature measurement is within the nursing scope and responsibility for accuracy. Then the assessment of fever response. I've listed by systems here some of the what we know, the physiologic responses to fever. The ECG, rhythm, ischemia, appetite, delirium, and seizure, those are italicized and in a lighter color font because there's no really evidence, yet people commonly think, oh, and when I trained in critical care, if the heart rate, when my patient had a fever, I was told through, my preceptors, like, oh, we need to reduce the fever because the heart rate will elevate, and that puts them at risk for ischemia, yet there is no evidence that that occurs in patients with fever. Same with delirium or seizures. Febrile seizures are a pediatric diagnosis and do not occur in adults. The next is our diagnostic workup, and this is a team effort to identify the cause of fever, and we'll talk more about infectious and non-infectious causes of fever, and the potential source of that infection or non-infectious etiology, which could be, a UTI, a medication, an antibiotic typically, a transfusion reaction. And again, it's team-based. The respiratory therapist assessment of their respiratory status. You may be obtaining sputum cultures. The nursing clinical exam and obtaining cultures is a part of that diagnostic workup. Now, new in my model, and less commonly thought about, is the next step would be a risk-benefit assessment for treating that fever. Do we need to treat the fever based on what the cause is, what the patient's response to fever is, because we all have different responses to fever, and the current clinical condition of the patient. And after that, we plan or decide, whether we treat fever, and then how. Do we not treat fever? Do we administer antipyretic medications? And when you see AP in my slides, that's antipyretic. Or do we apply physical cooling and antipyretic medications? And finally, we want to evaluate and reassess not just the body temperature, but the fever response, so signs and symptoms, and their response to the management interventions. Many of us know that we administer a lot of antipyretic medications, especially acetaminophen, and not all patients' body temperatures and fever response signs and symptoms resolve. So let's start with thermometry, because accuracy of body temperature monitoring is essential. Body temperature alterations, both hypothermia and normothermia is normal, so it's not an alteration, but then and higher body temperatures, whether it's fever or hyperthermia, are related to the patient's clinical disease state or their condition. Any therapies we're administering, medications can alter body temperature. We think of transfusions, intravenous fluids, any extracorporeal blood circuits, whether it's ECMO or CRT, and also exposure to the environment. During a bath, temperature can change. Procedural areas, the OR, as we know, is a cold environment. And then why do we monitor body temperature? Really to detect these alterations and changes. We also monitor and measure body temperature to evaluate responses to treatments and therapies. And then how? Well, the site and source. So if you look at the diagram on the slide there, the red area is really what we call core or central temperature, and it is definitely warmer than the periphery. And as you can see, the color changes as in the extremities. And when patients are febrile and warm, that changes, and we see that the heat can be dispersed somewhat more to the periphery. And it's essential that we're using a device that has accuracy and reliability established, and that we're using a safe method and we aren't causing harm through any temperature monitoring that we do. And then when and how frequently is also a part of thermometry. Do we do it continuously? There are continuous thermometry methods, or do we do it intermittently? And how often is that? Is it every hour? Is it every 4 hours? Is it every 12 hours? And it really should be based on the patient's condition, any therapies they're receiving, or your unit and hospital may have standards of care. There's not strong evidence to drive decision-making on the frequency, yet in a recent study, a meta-analysis in stroke patients, they actually did look at this, and continuous body temperature monitoring in the first 3 days after a stroke was associated with better outcomes regarding less mortality and less disability at discharge and 3 months out when they had continuous versus intermittent temperature monitoring. So thermometry sites, we have many. Let's go through the site options, and then I'll talk about some of the things that can affect the accuracy or reliability of temperature monitoring at these sites. The first 4, 1 through 4, are considered central or core and core surrogates, and the last 4 are considered peripheral sites of measurement. So let's start with the pulmonary artery. So that obviously requires a pulmonary artery catheter, of which we don't see in many patients, and clearly they would only be in the ICUs, typically with a PA catheter. It is considered the gold standard, and it is central or a core temperature. The location of that thermistor on the end of the PA catheter would be in the pulmonary artery. And the function of that thermistor is really the only thing that, and or the cable to the monitor would be some reliability risk points. And then the next is esophageal or nasopharyngeal thermometry, and that's considered a core or central temperature as well. It has excellent agreement with the gold standard being the PA catheter. The location of the tip of that thermistor, though, if it's esophageal, must be in the distal third of the esophagus, which is, close to a lot of central veins and arteries. And that has to be confirmed on chest x-ray. So that makes it limited, and typically patients are intubated when they have that esophageal probe in. It's not comfortable if you're awake and alert. And same with the nasopharyngeal. Typically that is used in the operating rooms, but can be used in the ICU in patients if they tolerate it. It can be uncomfortable, as I mentioned, and you can't it has to be in patients that are less mobile. The urinary bladder is the next. It's a core measure of core temperature. It has excellent agreement with the gold standard, especially during induced hypothermia in our post-arrest patients and in fever states. The accuracy does depend on the technology, so you want to check the manufacturer of the Foley catheter that you're using. Some require urine flow if the thermistor is internal in that catheter, and others now, the more current technology it does not require urine flow to get an accurate measurement. And studies have been done when patients get diuretics. Is it reliable? And yes, it is. And then the fourth core temperature measurement that we can do is rectal. Has very good agreement with the PA, typically a little bit higher than by 0.1 degrees Celsius to 0.4 degrees Celsius than the PA temperature. The location of that temperature probe really should be, it's recommended that it's in the rectum at least 6 centimeters, and we want to avoid its use in neutropenic patients. And I just caution that warming and cooling devices, let's say you had a cooling blanket and you also had someone with a rectal temp probe, that if it's exposed to the temp probe anywhere the thermistor is, or if that probe's out a little, you would get a false reading. Because it would be cooled or warmed by if you had a warming device on the patient. So you want to make sure you're assessing your patient's clinical picture with their temperature. And then the oral temperature is considered peripheral. It's one of the most frequently methods of measuring temperature in hospitalized patients. And it's essential that thermometer probe is placed in the posterior subbuccal area under the tongue, so as posterior as possible and not anterior. We know that oxygen therapies that are aerosolized, face masks, they do affect oral temperature, so they should not be taken while patients are receiving face mask oxygen. Oxygen via nasal cannula is okay. And studies with high flow oxygen therapies, which the temperature is altered, have not been well studied, so we don't know about that currently. That's a great study if anyone is looking for a research topic. Patients that drink hot or cold fluids or were smoking, which hopefully they weren't, or eating food or chewing gum, it really is recommended that you wait 10 to 15 minutes before taking those temperatures. And then the tympanic infrared thermometers and the temporal artery thermometers, they're both considered peripheral, and they both have poor agreement, and they are actually recommended to not use in ICU patients. And so hopefully in your ICUs you're not using them, and I know a lot of recovery areas, PACUs use them, and those, to me, sometimes can be ICU level patients, so they are not recommended. And the last one, the least reliable, the least accurate, is an axillary skin temp in adult patients. It's different in children who don't have a lot of adipose tissue, and their skin is different. It's considered peripheral. It has the worst agreement with the PA temperature in adults. It can be up to 1 degree lower, and it's, again, like I said, recommended not to be used. Are not recommended for use. So always evaluate your patient's body temperature that you measure with the patient's clinical condition and their high risk. We had a case example is a hem-onc patient that had leukemia, was on chemotherapy, was neutropenic. The nurse took the oral temperature on the acute unit, and it was 38.6, and the patient had said he had drank some hot tea, so he repeated it a minute later, and it was still high at 38.3. So then decided to just use the axillary and took an axillary temp, which was 37.1. And a few hours later, the patient, when the shift changed, had an oral temp that was elevated, febrile, and was sent to the ICU with sepsis. So just really in your standards of care, policies, procedures for troubleshooting, you want to have, what are the alternatives when you can't use the most reliable and accurate measure. And that 10 to 15 minute wait to do the oral is better than moving to a different method of thermometry. And I have on the slide the forehead core and the brain. Those are newer methods of thermometry that have limitations, but there's some research going on around the non-invasive zero heat flux method. So in summary, around thermometry, you just want to make sure that you know the indications for body temperature monitoring, and think about beyond the ordered vital sign frequency. If your patient has signs or symptoms of the fever response yet are having chills, you may want to monitor their temperature more frequently. We've talked about assessing temperature before and after therapies that may alter temperature, maybe an antibiotic, maybe a transfusion. Obviously, those are required. And then the thermometry method and site we've gone over, but it's essential to use the most accurate and device and most reliable device, as well as it being safe. The more invasive, they have risks. If you have a bladder temperature monitoring Foley, do we leave it in for the temperature monitoring, or do we take out the catheter because they don't need it and reduce the infectious risk of urinary tract infection? Critical thinking, consider the body temperature in relation to your clinical exam, as well as considering the patient's history, their risk factors for infection in particular, and then their current clinical condition and therapies that might predispose them to fever or even hypothermia. And we need more research in this area to come up really with a non-invasive device, not just for continuous thermometry, but even intermittent options, especially for our oncology population that are out of the ICU. Okay, let's define fever. A fever is defined as a regulated elevation of core body temperature, and it's regulated in the hypothalamus in the brain. The Critical Care Medicine Association, as well as the Infectious Disease Society of America, have defined in 2008 an body temperature of greater than or equal to 38.3 Celsius, which is 101 degrees Fahrenheit, as a definition of fever, just to have everyone start, especially in research or clinical improvement projects in the units, to use this as a standard temperature. And the Surviving Sepsis campaign changed their body temperature threshold for fever to 38.3 in 2013. In the literature, it's variable and steady, so you want to make sure and look at that if you're reviewing the literature. The incidence of fever ranges from 15 to 70%. In the past 10 years, the incidence has decreased, and I think that's related to all of the improvement activities in ICUs, in particular, getting lines out, central lines out, reducing ventilator days and getting patients extubated. ICU liberation, we're using less sedatives, we're mobilizing patients, so we have less incidence of infection and fever in ICUs today, and it's probably more around the 15%. So let's talk about kind of fever and a little bit of the physiology. The body's thermostat is in the brain. It's in the hypothalamus. The regulatory center controls kind of what the set point is, or the temperature should be. So for example, if I have an infection and bacteremia, it'll increase the set point, let's say, to 38.8. Or if I'm too hot, I've just exercised or been out in the desert, it will set it to 36 if I need to cool down. This center controls both behavioral and physiologic responses to fever and to cold situations. So keep in mind with these mechanisms on the slide there, the opposite things occur if I am too cold and if we're too cold and need to warm up. So if my thermostat increases to 39 because I have, let's say, a strep infection, And the bacteria and that inflammatory response of infections releases cytokines, interleukins, and tumor necrosis factor. And those are what we call pyrogens, and they go up to the brain and they stimulate prostaglandin release, and that changes, prostaglandins, are essential in changing that temperature set point. So to increase my temperature from, let's say, normothermia of 37 to 39, my body needs to do two things. One, it needs to prevent heat loss, and then it needs to increase heat production for my body temperature to get to that point. So preventing heat loss, we seek warmer environments. These are behavioral things. You guys know this. If you're cold, you move into an area that's warmer. If you're hot, you move into the shade, and the opposite. So to prevent heat loss, we want to seek a warmer environment. We'll put on clothes, we'll huddle, we'll put our hands under our armpits. That's not something we're taught. It's a behavior that is a part of this thermoregulatory response. We'll have vasoconstriction, in particular of the vasculature in the skin. Our fingers get cold, our toes get cold, and then we might get goosebumps, which creates little valleys in the skin to try and retain heat. And for heat production, if we need that as well, we increase our muscle tone. Our muscles will get a little, they'll contract a little bit more. I think of when I sit at my son's baseball games and it's cold outside and I come home like, why am I so tired? Well, my muscles have been contracted for 3 hours watching that very long baseball game. If we need to shiver, our muscles will shiver to generate heat, because if we're not reaching that thermostat's new set point. And shivering increases oxygen consumption as well as CO2 production. So that's one of the mechanisms for it increasing our respiratory rate, to get rid of that CO2 that's produced with shivering. We might have thyroxine produced, and that increases metabolism. And then we have what's called non-shivering thermogenesis. Babies and animals have brown adipose tissue that, without shivering, it can generate heat by the breakdown of this fat. And they have recently found that it's also in adults, in our thorax and in our mediastinum. So we do have a way of this brown adipose tissue that, when it breaks down, generates heat. And then we have our catecholamine release as well. The stages of fever include the 4 stages here, and you guys have all probably experienced them or seen them in your patients. The complaints of headache, malaise, or discomfort. They might seek warmth. Stage 2 is the chill phase, feeling cold, tensing muscles, shivering, maybe some vasoconstriction. The stage 3 is when the body temperature actually is increased, and complaints of feeling hot and headache may be present. And then stage 4 is when the fever breaks, or what we call defervescence, sweating, and diaphoresis, which help evaporate heat. In the skin, I think this slide's important. If you look at the retain heat, mount to fever slide, when we want to retain heat and keep it central, we close off those thousands of AV shunts that are in our skin, and the blood then doesn't go to the surface, so there's less radiation of heat. And then when we need heat loss and to defervesce, they open up, and heat is evaporated off the skin. So these are some of the physiologic fever responses. Our heart rate, we know, increases on average of 5 to 6 beats per minute. And then blood pressure can increase in the early phases and then decreases during defervescence when those shunts open and we have an increased vascular capacitance, or a reduction in systemic vascular resistance. And there are some stroke volume and cardiac output related changes, but they're usually related to the heart rate changes. And then for the respiratory response, we know that respiratory rate increases, and it's typically to exhale that CO2 from the CO2, increased CO2 production with fever, and also brings inhale cooler ambient air. So 2 mechanisms or reasons for respiratory rate increase and minute ventilation increase with that increase in tidal volume. Also, if someone has fever from infectious origin, they also might have a metabolic acidosis, a lactate acidosis, and that will also drive the minute ventilation to increase. And I've mentioned the metabolic changes. Other definitions, hyperthermia is not equal to fever. So hyperthermia is an unregulated, remember fever was regulated by the hypothalamus. So when it becomes unregulated, that rise in body temperature is elevated, and it may be to the upper limit of 42 degrees Celsius, which is quite high at 107.6 degrees Fahrenheit. What are some of the causes? We think of heat stroke, serotonin syndrome, which is related to a lot of SSRI medications, and then neuroleptic malignant syndrome, which is an adverse reaction to dopamine antagonists like Haldol or even Compazine. Malignant hyperthermia is a specific diagnosis of the hyperthermia category, and patients can have this after exposure to anesthetics like isoflurane or succinylcholine, a neuromuscular blocking agent. It's an inherited genetic disorder, so we know if it's hereditary, and muscle rigidity and muscle breakdown occurs, and it's an unregulated high temperature, and the treatment is to physically cool these patients. They're given dantrolene IV, which reduces some calcium release, and treat the hyperkalemia related to this very rare but potentially fatal disease. So what are some of the causes of fever? We know infection of all the different potential organisms or pathogens. Drugs can cause fever. The mechanisms are not really well understood. There's central or neurogenic fever, we'll talk more about in a minute, and then the many immune-mediated. So anytime there's inflammation with those cytokines, that interleukin and tumor necrosis factor being released that stimulate fever, they're actually pyrogens, can be any of these disorders. Tumor cells release those cytokines, and anaphylaxis, organ transplant rejection are examples. So neurogenic fever, there is a diagnosis by exclusion. So you have to rule out that they have infection or any other drugs are causing this. So it's a non-infectious type of fever. The incidence is high, as you can see in the slide, in both traumatic brain injury and subarachnoid hemorrhage, the stroke patients. The mechanism is unclear. They know it's related to injury inflammation around, near the hypothalamus. And the patients with blood in their brain or intracerebral hemorrhage are at high risk for fever. And then there's a spinal cord injury and fever in the neuro population. When patients with spinal cord injuries, especially high up in the cervical spine, they can have fever of non-infectious or infectious etiology. And a recent study found that there's a higher mortality in this patient population when the fever is neurogenic and not infectious. And they think it's related to autonomic dysfunction. And it's also been coined the term quad fever because if it's a high cervical injury, they're quadriplegic as well. And it's unclear what the cause is or idiopathic. They're very high fevers. They do not respond to antipyretic medications or physical cooling, and it is usually fatal. And I've seen this once in a patient in a motor vehicle accident, and we couldn't do anything to get that temperature down. Postop fever is another type, non-infectious. The incidence is anywhere from 24 to 50%. And in one study in surgical patients, we spend a lot of time culturing them and working them up, but that usually yields few infections. So it's usually related to that inflammatory response from the surgical procedure. So we need to think about fever types and the way we evaluate them and whether we should manage all fevers the same. So is fever harmful or helpful? Fever's been viewed as helpful and harmful at different times in history. The question's been debated over many years. I think the reason that the question has not been answered is that we've not studied outcomes of fever and fever treatment by population. So we throw all the patients together, we're going to have, mixing apples and oranges. We don't get good answers to scientific questions. So a British physician in the 17th century was quoted as saying that fever is nature's engine, which she brings into the field to remove her enemy. Clearly in that 17th century, it was seen as helpful. And we know it's a complex response. We've talked about some of the mechanisms here. So fever and infection, fever's adaptive. If it wasn't helpful to sustaining the human race, if you will, we would have fever would have gone away. So it's an adaptive response to severe injury or infection. We know that the benefits of fever include inhibiting bacterial growth, stimulating the immune system, facilitating repair of tissue. One thing it does, it stimulates storage of iron into our liver or spleen and reduces circulating iron. Well, what does that mean? Well, bacteria requires iron to sustain. So these things are happening, and it is an adaptive response, a helpful response in infection. In 2011, the American Academy of Pediatrics had a campaign to help not just pediatric clinicians, but also parents, educate about fever because of this fever phobia. And they really used flyers like the one you see on your slide and wanted to focus beyond the body temperature. What does your child look like? How active are they? Are they taking fluids? And they really focused on antipyretic medication safety. So let's talk about fever and outcomes and fever suppression and outcomes in this population, and what do we know? September is always Sepsis Awareness Month, and I was glad to see this last September, a few months ago, that in their campaign, they added under their acronym of symptoms and signs, shivering, fever, or very cold, to be monitoring our patients for. And I think in the past, everyone's been focusing on fever, but that shivering or very cold, remember, is that early stage of fever, and that calls when, if a patient is complaining of that, to get them the blanket, the warm blanket, hopefully, and also monitor them a little more frequently, both their body temperature, and go in and check on them more often than your standard Q4 or 8-hour vital signs. So what do we know from the from studies that this was a large ED study in septic patients where they found that only 45% of all these patients with sepsis actually had a fever, so not to think, oh, they must not be sick if they don't have a fever, and that 23% had low body temperatures. And we know hypothermia is also one of the diagnostic criteria or for SIRS and sepsis. Among the vital signs in this study, body temperature was the best predictor of mortality, more so than heart rate and blood pressure. And they found that if the patients had fevers, they had more prompt administration of antibiotics than patients that didn't have a fever. And the lowest mortality was in patients with fever. And this is from that same study, and you can see that on the x-axis is body temperature, on the y-axis is their mortality, and it's highest in patients with low temperature, and the lowest mortality is in those patients with high temperature, even greater than 41 degrees Celsius. Another meta-analysis, which is really a high-grade study, it takes many studies that meet criteria and analyze them, that the larger sample size. So this was 42 studies of patients with sepsis, and over 10,000 patients, and compared to normothermia, that fever was associated with a lower mortality, and hypothermia was associated with higher mortality, and that is seen across many studies for decades, that hypothermia is always associated with the highest mortality. In ARDS patients, this is a study that I did here looking at over 900 patients that were enrolled in the ARDS FACT trial, and I looked at their body temperature at baseline or early in their ARDS. So majority of those patients, the pneumonia actually was 47%, and of the patients had pneumonia, and 23 had sepsis, so infectious etiologies equaling 70% of the whole sample, that their body temperature independently was associated with mortality. So for every 1 degree increase in their temperature, their mortality was reduced. And look at that diagram. It's similar to the previous study we saw, where the low body temperatures have the highest mortality and the high temperatures have the lowest mortality. Okay, so a large trial from the FACE group, which is from Japan and Korea, they looked at patients with fever, and they looked at those that had sepsis and those that did not have sepsis, broke them into two groups. And they had patients from over 25 ICUs in these two countries. And they also looked at antipyretic treatments, both medications and physical cooling. And what they found in the patients with sepsis that had a fever, APAP, which is the acronym I use for acetaminophen, and nonsteroidal use were independent predictors of mortality. So if a patient had a fever and sepsis and received those medications, the odds of death were almost doubled, the odds ratio of over 2. And that in that population, just having a high body temperature alone, like the other studies, was not associated with increased mortality. In the non-septic group, they had a different finding where those antipyretic medications, they didn't have an impact. So you could give them or not, they didn't impact mortality. But in that group, they did find that higher body temperatures in the non-septic group were associated with higher mortality. And that physical cooling, which they do a lot more in Asia than we do in the US, did not have impact on mortality in both groups. This study came out in septic shock patients from France, where they looked at external cooling to bring the patient's temperature, febrile patient's temperature, to the normal range. And they compared it to patients, they randomized patients to either cooling or to just receive no antipyretic interventions. And their primary outcome was to look at the number of patients that had a lower requirement for vasopressors at 48 hours. So multi-center, 200 patients, well-designed trial. They found that body temperature was lower if they externally cooled. They found no difference in their outcome of vasopressor use at 48 hours. They saw a little less vasopressor use at 12 hours. Now, they do report that there's a lower mortality at 14 days in the cooling group. And a word of caution when reading the literature is that this study was not adequately powered or didn't have the sample size to say that cooling causes lower mortality, but they did present that finding. And of course, if you're cooling people and with all the shivering, more patients require neuromuscular blocking agents, which keeps them on the ventilator, as we know, a little bit longer. So the next study is the largest trial done in Australia and New Zealand, called the HEAT trial, where they evaluated acetaminophen versus no acetaminophen in febrile patients. And the findings here were that there was no difference in ICU length of stay and or mortality at 28 days or 90 days. And that the lower mean daily body temperature was only reduced by, less than 0.3 degrees Celsius in the acetaminophen group. So we give a lot of acetaminophen. It doesn't make a difference on mortality. Should we continue to do that is the big question. The next study is a systematic review, and I'm not going to spend a lot of time here. Basically the same findings, that there's no difference in whether you use antipyretics, either medications or physical cooling, in patients with sepsis, not just in their mortality, but also in reversal of their shock, of new hospital-acquired infections, minute ventilation, or heart rate. No difference. So we're going to move along here, a few more minutes here. So ibuprofen, I'm not going to spend a lot of time here. It's one of the antipyretics that we have available, both in IV and enteral forms. It's not typically used in hospitalized patients for fever because of all of the warnings that you can see on the slide, including GI bleeding and the cardiovascular events. Acetaminophen, the most commonly used antipyretic kind of internationally, not just in the US, and it's our first line treatment in hospitalized patients. There are warnings that people aren't typically aware of. It's not as benign of a drug as we may think. People can have allergies to this medication. We know about liver toxicity, which is usually related to dose and liver function of the patient. There are severe skin reactions. Even one dose, you can get Stevens-Johnson syndrome, where all the skin blisters. So looking for those, monitoring patients after getting acetaminophen is important. So what do we know about the effects of IV acetaminophen or acetaminophen on body temperature? I did a randomized controlled trial here at UCSF looking at this because there had never been a study in critically ill patients looking at the effect of acetaminophen on body temperature in critically ill patients. Healthy volunteers, yes, but not ICU patients. And we also had a lot of reports, case reports in the literature about decreased blood pressure and hypotension associated with acetaminophen, but not really a randomized controlled trial which can tell us whether it causes hypotension or not. So that was done here in our ICUs a couple years ago. And so does it change temperature over time? This is a 4-hour on the x-axis time frame, and the degrees Celsius it changed. Yes, it can reduce body temperature. The peak is at 2 hours, and then it starts normalizing, and the difference is not significant between placebo and acetaminophen at 4 hours. Heart rate change, it's significant again at 2 hours, but is a heart rate change of 8 beats per minute on average clinically meaningful? You can ask or evaluate in individual patients, but at 4 hours, it's not different. And it's a challenge because the frequency of acetaminophen dosing is every 4 to 6 hours. We can't give it every 2 hours or we'd be dealing with toxicity issues. One of the most important findings from the study was the blood pressure changes for MAP and SVP and diastolic pressure. They dropped significantly, not just statistically, but clinically meaningful. The average drop at 2 hours is 24 millimeters of mercury. So someone can be 120 systolic and it can drop to 100. But at 4 hours, it's no different. So are we monitoring our patients' blood pressure after giving them more frequently to see if they have hypotension and potentially treating it if needed? In terms of respiratory rate, this is consistent with other studies that have actually measured respiratory rate. It doesn't change it that much, even though we know respiratory rate increases with fever. Not significant clinically or statistically at any time point. So nearing the end, a quick case. We have a patient with coronary artery disease, heart failure, hypertension, diabetes, and Alzheimer. He also had obstructive sleep apnea and was on a little oxygen at night at 2 liters. He had a recent hospitalization for cholangitis and had bacteremia. He came to our ED with acute shortness of breath. He denied any chest pain, had some leg swelling, and or denied any leg swelling or fevers and chills. So at 2 o'clock, he had an oral temp of 36.9. You can see the blood pressure's normal, heart rate 70, respiratory rate's elevated at 24, and was on required 4 liters to be 100% saturated. Sleepy but arousable, normal heart rate rhythm, warm extremities. Little tachypnic on his respiratory exam, diminished breath sounds, mild work of breathing. Everything else was pretty within normal limits. So as you can see in this chart here at 14:30, those were his vitals. 2 hours later, rectal temp was done and it was elevated and it was 39.4, but notice his heart rate's gone up, but not into what we would call it's not tachycardic per se. Blood pressure's holding on, respiratory rate increase. He was given acetaminophen 650 milligrams at that time. And then I just want to jump to 18:30. We see the blood pressure change. The respiratory rate hasn't changed that much and the heart rate hasn't changed. And he ended up on some norepinephrine. So the studies with hypotension related to acetaminophen have shown that patients do require sometimes fluid boluses and even vasopressors. And this patient did have an elevated lactate and a bacteremia and had septic shock, and having septic shock and heart failure together, not a good combination, but it's hard to tell when you have acetaminophen mixing it up. He likely would have dropped his pressure eventually, but it was probably facilitated by opening up those AV shunts to help reduce the temperature. So in closing, we want to anticipate the future. What is fever care in our ICUs and hospitals? I think it's time to reevaluate our goal of fever suppression. What is our target? It really should be beyond the normalizing of body temperature. We need to look at the whole patient's, all their systems and organ function. Assessment and management of fever responses. I think we could do a risk stratified effect, and we need more evidence to really guide this practice. And then my clinical practice recommendations are really we need to monitor body temperature using accurate and reliable methods, and always document the source or the site with each measurement. Monitor our patient's body temperature and their clinical response. How do they respond to the fever? Evaluate and identify the source of fever. Again, that's a team effort. Consider indications for fever suppression. Why do we need to bring their temperature down? What are they at risk for? Reassessing their response and collaborating with the team on the plan of care. And then definitely share the evidence and these questions that have come up today with your colleagues, and they may lead to future research or quality improvement efforts. Well, this concludes my segment of this webinar, and I will pass the presentation over to Mary for questions and answers.
Thanks, Hildy, so much for your presentation. As always, I am learning so much from you. So just to let everyone know, continuing education for nurses and respiratory therapists, again, this is approved for 1 contact hour, and you can obtain your CE credits by going to saxtesting.com/MHB. And again, support for this educational activity was provided by Stryker. And so with that, let's get some questions started. First, we have a question from Julie. Julie, thank you so much for sending in your question. The first one, Julie's question is about how high of a fever is good versus detrimental.
Oh, thank you for that question. You know, that's a tough one. I don't think anyone really knows like how high, like is a fever of 39 better than having a fever of 38. So really tough to answer, yet we do know that there's no association with the fever magnitude, so how high the fever is, and the signs and symptoms. So if someone's shivering and chills, there's no association with the fever response with the actual severity of the infection. So that's what we do know. Thank you.
Thanks. This next question is from Nanny, and this is an interesting switch because you're focused on more of the inpatient setting. Nanny's question is, should the use of acetaminophen be discouraged in home treatment of fever?
Oh, that's a really great
question.
Isn't that a great
question? Yeah.
You know what? No, especially because we're in the flu season. So there was a study, a prognostic study published a few years ago that was related to the flu and the flu epidemic and pandemic. And they talked about, you know, when people don't feel well, that malaise or have a fever at home, I've done it, take ibuprofen or acetaminophen, and then we go to work. But we're still viral shedding. And they say with people feeling well and going out shopping and doing things that we can spread, in particular, viruses, you know, more readily by being out rather than staying home and, you know, under the covers or and doing things like that. So a lot of my friends that know this work or have heard this, they say, I always think about, oh, should I take it at home as well? So it's not been studied in the outpatient except for in children with chickenpox, where the viral shedding was prolonged in the children that were randomized to take acetaminophen. So we do know that about viruses. So something to consider, absolutely.
Yeah, I think even to segue off of that, and that was Janie's question. I'm sorry for mispronouncing her name. I also think, can we speak to the use of acetaminophen before patients arrive to the emergency department who may be in the early signs of sepsis? What best practices would you give our people on the webinar?
If you're planning to come to the hospital, which no one plans to, an emergency like that, you know, I don't think we have enough evidence to say I would discourage it, but if you do give it, to definitely tell the nurses and providers when you gave it, what you gave, and how much you gave, so that they can evaluate the patient knowing that exactly. So very important.
I think too, also as providers, we need to understand and ask those questions during the intake section while you're assessing your patients, so that we as providers can also have that information readily available. I think especially for those early stages with the cold, that kind of cold sepsis and stuff. Okay. The next question is from Sylvia. Oh, this is a great question also. What are the thoughts on the use of aspirin for fever?
So aspirin falls into kind of the non-steroidal. You know, a lot of people just don't use it because of the other risk factors, and that acetaminophen and ibuprofen are more effective at fever reduction than aspirin, and ibuprofen is more effective than acetaminophen. Hence when we wonder like, well, why don't we use it in the hospitals? But all the risk and adverse effects in that profile are so much greater. But a lot of people haven't kind of researched it, just especially in children, you know, the risk of aspirin toxicity, the GI bleed and other effects of aspirin in adults. It's just not, you know, it's not as effective as well in the body temperature reduction.
And Sheila also has a comment or a question that's coming in similar to that. In her acute care unit, she sees alternating ibuprofen and acetaminophen given every 6 hours. And I was thinking that as well. What are your feelings on kind of alternating these medications and then also giving these type of fever reduction medications around the clock?
So alternating has been done, I know it was more so in pediatrics, and there's not been a lot of study on whether it's more effective. I think the reason for doing that is to reduce the risks of both medications in terms of their adverse effects, and or they can see that which one does the patient respond better to. So I think the second part of Sheila's question, Mary, what was that again?
So her specific question was alternating between acetaminophen and ibuprofen.
Around the clock.
Around the clock. Yeah, and that's kind of my question is there a clinical place for around the clock treatment like this?
Not necessarily for fever. Now, the rare critically ill patient, and our respiratory care colleagues will appreciate this, the rare critically ill patient with severe ARDS that has a huge dead space and their PaCO2 is 80, on the highest ventilator settings possible for that patient, and they get a fever, and so that's increasing CO2 production. So in those rare cases where it affects our ability to ventilate patients, then that would be a case, and sometimes that's where we have employed ibuprofen and or physical cooling to override that response, but that is rare. And the around the clock, back to that segment of the question, again, no strong evidence. We know the patients are getting around the clock acetaminophen in hospitals nowadays for pain management, the non-opioid pain management, and we do need to consider that they're at risk for infections as well, and we could be masking it. So also looking at other signs and symptoms beyond the body temperature are going to be important there.
Thanks for that, Hildy. So Julie has a great question about septic patients with increased temperature and having increased metabolic demands. How would you suggest handling those metabolic demands?
Again, thank you for that question. It's interesting. So data from literally a century ago that we all quote in clinical practice, or you may hear in clinical practice, is that, for every 1 degree Celsius increase in temperature, metabolic, rate goes up by 10%. And that 10% increase in metabolic rate has not been associated with bad or negative outcomes. So think about your critically ill patient with early mobility nowadays. You're sitting them up, they're getting their work of breathing, their metabolic rate increases. I don't think anyone's actually measured it, but it does increase, and it's not detrimental. So yes, it increases metabolic rate, oxygen consumption, CO2 production, yet it's never been associated with poor outcomes. So that definitely gets used. We want to reduce their metabolic demands. Well, is that harmful or not? It's a question to be considered. Thank you for that question.
The next question from Karam is, what are the dangers of not being able to get the patient's temperature down in an adequate amount of time? And maybe even to segue from that, what would be an adequate amount of time? When should we really be concerned if the patient is febrile over what period of time?
So that would, there's persistent fever where it just doesn't break. That's not as common as what we all see in practice. Well, they have a fever and then it goes, even if we didn't treat them, we do see it subside and then it may rise again, kind of this different patterns to fevers. There isn't evidence that a persistent fever is more detrimental than one that's intermittent. And is it the sum of body temperature over a day versus these peaks? Because I always say, on rounds when we hear, the providers are presenting a patient and they'll say, their peak temperature was 39. Well, it could have been 39 all day, or it could have been 39 once for 2 hours, or 1 hour even, or it could have been 39 3 times during that day, but then they'd effervesce. So really looking at temperature burden hasn't been something that is in clinical practice yet, and so we don't have answers to that in terms of evidence to say that a persistent fever is better or worse. So sorry, I can't answer that more specifically.
There's one last question from Michael. Hospitals are penalized when a patient has a fever of greater than 38 degrees Celsius and a physician wants specimens collected such as blood or urine and something grows in the culture. Any thoughts on this?
Mary, can you say that again, the beginning of that?
Sure. So Michael's speaking to hospitals that are penalized for different positive cultures when a patient has a temperature higher than 38 degrees Celsius. And what are your thoughts on that? Some of those regulatory issues that go with getting cultures after a fever.
Okay.
And what you can...
Yeah, that may be a hospital-specific protocol. I know there are regulations, for sepsis, and, if a patient has the clinical presentation, the signs of SIRS, including a body temperature, but also other signs, in terms of their white count or their heart rate, respiratory rate, etc., that you're supposed to, in a timely manner, work up the patient. So do the diagnostic workup, so obtain cultures, and then give them antibiotics, broad spectrum antibiotics within that hour or time frame if that's your hospital's kind of standard and policy. So yes, obtaining them. I thought you may be asking the question, which I commonly get asked, is like, is it really important to not treat the fever before you get the cultures? And I remember as a new nurse saying, people said, oh no, don't give them, the acetaminophen until after you get the cultures, because it will affect the yield, the growth in the cultures. And there's no evidence to that effect. So if you are going to treat, you can do that and then get your cultures. It's not going to affect the yield from any type of blood, urine type of culture. So I hope I answered that question for him. Thank you guys so much.
I think my last question for today is going to be just anything related to age-related differences with fever that you can, one last comment on that?
Yes, so I showed you guys the pediatric campaign, but children less than 5 are at risk for febrile seizures. Now, an adult can have a seizure, can have a fever, and they may have a seizure as well. And those are typically adults that have like an encephalitis or some kind of an infection in their nervous system. But I think in children, I think they need to monitor the whole patient and their clinical signs and, their lethargy, their activity, get them in. But beyond that, there really isn't, and including in the geriatric population, really no difference in this.
Well, as we close, I'd like to hand the controls back over to Emily.
I'd like to thank you very much for your time, both Hildy for this very informative presentation, and as well to you, Mary, for being our moderator today. It has been such a pleasure working with you both, and I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now, this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.